So, Kani, நம்ம ஆரம்பிக்கிறோம்.
Yes, sir. Meeting record பண்ண ஸ்டார்ட் பண்ணியாச்சு sir. Will do, sir.
Okay. Right. Good morning to all of you. We will start at another session of the Clinical Neurology Forum. And I am happy to state that this month and at present, the Neurology Department at Savitha Medical College under Professor Vasudevan will be presenting interesting cases and discuss. There are 2 cases to be presented, and I request Professor Shivaji, who is a professor of neurology at Madras Institute of Neurology, to chair the session and conduct the proceedings. Welcome, Professor Shivaji, sir.
Thank you, sir.
Thank you. Thank you. For those who do not know, Shivaji is a psychiatrist and a neurologist. And he has been with us at the Institute of Neurology for, I think, close to 10 years now. And he will be conducting the proceedings. Thank you. Thank you, Professor Shivaji. Yes, sir.
Good morning to all.
Yes, good morning.
Morning.
Today we have a 2-case presentation. A resident from Savitha Medical College. The first case is going to present by
Monica ma'am, sir. Monica ma'am.
Monica.
Yes, sir.
Yes, sir. Good morning, everybody. This is Dr. Monica from Savitha Medical College. So before I present, I want to thank my professor, my chief, Dr. Vasudevan sir, Dr. Vinod Khanna sir, Dr. Shivaji sir, Dr. V. Natarajan sir, and my faculty, Dr. Satish sir and Dr. Nirmal sir, for giving me this opportunity. And today I'm going to present an interesting case of movement disorder. So a patient by name X, aged 63 years, gender female. She's a right-handed individual who studied till 5th standard in Urdu medium. She's a housewife by profession. She was residing at Chennai. Informant is husband, and the information given is reliable. Chief complaints: there's a difficulty in walking since 3 years, abnormal posturing of left upper limb since 1 year, involuntary movements of right upper limb and lower limb since 10 months. Pre-morbid history. Patient used to wake up by 6 a.m. in the morning, and after completing the morning routine, she used to cook breakfast and lunch, clean the house, wash the utensils, wash clothes using washing machine, and finish her course by 11 a.m. She used to take rest in the afternoon till 3 p.m. In the evening, she used to prepare coffee and serve the family. Later, after preparing, she used to watch television from 8 to 10 p.m. and then go to sleep by 10:30 p.m. She used to accompany husband to buy vegetables and household groceries once in 10 to 15 days and help grandchildren in packing school bags while going to school. History of present illness. Patient was apparently normal till 3 years back.
Monica, how old is she?
She's 63-year-old.
Okay, thank you. Thank you. Go ahead.
Okay, sir. Patient was apparently normal till 3 years back. Patient was able to do all her daily activities by herself. Then patient developed difficulty in mounting bike, difficulty in gripping chappals, more with left lower limb. Then it progressed to difficulty in walking, climbing stairs, getting up from sitting posture, which was insidious in onset, gradually progressive in a span of 2.5 years. She used to walk with support since 1 year, and for the past 6 months, she is ambulant using wheelchair. And since 3 months, she is completely bedridden. There was abnormal posturing of left upper limb involving elbow, forearm, wrist since 1 year, because of which she was not able to do any activities with left upper limb. There is no diurnal variation and it's not task specific. Patient was then taken to a government hospital and was treated with certain medications. Then patient started developing random, involuntary, unpredictable, non-pattern, irregular...
Monica, do you have any details of the medications given to her?
Yeah, sir. Patient is being started. Yeah, sir. Patient is being started on Sindopa 110 mg, like TDS, sir, along with Pacitine 2 mg, like twice daily, sir.
Okay.
Yes. So movements, the patient then started developing random, involuntary, unpredictable, non-pattern, irregular movements of right upper limb and lower limb. Movements didn't persist in sleep. Movements were not altered by particular position and they were not affected by environment, temperature, or emotion. There was spillage of water and smearing of face during feeding. Difficulty in holding objects, combing hair because of right upper limb involuntary movements. Despite modifying the treatment, movements initially improved but did not subside completely, and the movement's amplitude worsened for the past 3 months. Patient gradually stopped daily activities like cooking since 1 year. In the course of the disease, there is no involvement of head, neck, and trunk also. She comprehends instructions properly and maintains conversations. She is socially active and she actively takes part in conversations with friends and family members and contributes in decision making. She is now completely dependent on caregivers for activities of daily living. Negative history. There is no history of change in behavior or ritualistic behavior or change in diet pattern. There is no history of excessive, inappropriate laughter or crying at improper situations. No history of forgetfulness. No history of acting out of dreams during sleep. No history of vivid dreams, hallucinations, or delusions. No history of slurring of speech. No history of bowel and bladder involvement. No history of dysphagia, dysarthria, nasal regurgitation. No history of ptosis, double vision, or decreased vision. There is no history of hard of hearing. No history of fluctuations in sensorium. There is no history of falls anytime during the illness till date. There is no loss of sensation over face or any difficulty chewing or swallowing. No history of atrophy or fasciculations. There are no sensory abnormalities. No history of palpitations, excessive sweating, decreased appetite, or early satiety. There is no history of myoclonus, no rest tremors, no history of blacking out of vision, no history of loss of consciousness, no history of drop attacks or head trauma. There was no history of any significant weight loss or any history of exposure to any known toxins. Past history. She is not a known hypertensive, diabetic, or thyroid disorder, or CAD, stroke, seizures, or syncope. There are no recent history of any blood transfusions too. Personal history. She is a non-vegetarian. Sleep was normal. Bowel and bladder habits were normal. Treatment history. Patient was initially started on dopaminergic drugs, later which patient developed involuntary movements of right upper and lower limb. Family history was not significant. And this is a pedigree chart. The affected person is this 63-year-old, and along with her, there were 4 siblings. Out of these 5 people, 1 is affected and 1 is living at present, and the other 3 were expired, deceased. The first one at the age of 72 years, the cause is unknown, and the second one and the third one, they got deceased at the age of 68 and 66 years respectively, with because of CAD. And she is having 3 sons, aged 32 years, 30 years, and 29 years, who are not affected till date. Summary: 63-year-old female, homemaker with no previous comorbidities, right-handed individual. She presented with insidious onset, gradually progressive difficulty in walking, initially with left lower limb, but progressed to bedridden state for the past 3 months. Left upper limb, abnormal posturing, and right upper and lower limb involuntary movements, which were random, non-patterned, repetitive, abnormal movements involving both distal and proximal, without any cognitive cranial nerve, motor, sensory, cerebellar, or autonomic dysfunction, and without any significant family history. So, symptom analysis.
1 minute. I thought you said 2 of her family members were affected. No?
No, sir. 3 of them were deceased because of unknown cause, because of age, they were saying, sir. And 2 of them because of heart attack, they got deceased, sir.
Okay.
Only is the one who is affected as of now, sir.
Okay.
So, symptom analysis. There's a difficulty in walking due to spasticity of both right and left upper and lower limbs. Left is more predominant than right, and it can be localized to bilateral corticospinal tracts above the level of pons.
No, in the history, how did you come to the conclusion it was spasticity?
I think it is a spasticity or rigidity?
No, sir, it is spasticity, sir, actually.
Okay.
How do we know it is not weakness?
No, sir, the weakness is because of the spasticity, sir.
Yeah, from the history, how did you come to that conclusion?
Oh, sorry, sir. I mean, after the examination, I'm supposed to.
Sir, can I speak, sir?
Yeah, please go ahead.
Sir, the patient actually complained of weakness, sir, for the past, before she presented to us, she was having weakness for the past 1 or 2 days. Clearly, the weakness was there, sir, so that she was not able to do any activities with left upper and lower limb, sir. But
yes.
Progressive, sir.
Correct. But how do we come to the conclusion? that we-
Spasticity cannot be commented at this point, sir. Maybe after examination.
Okay.
So,
Thank you.
yes. So general examination, she's average built and good nourished. And
Now, what was the previous slide? Sorry, I missed it. In our talk, we missed it. The previous slide, what did you present?
no, so after the summary, I'm supposed to.
Okay, right. Then go ahead.
Yes. And there's no pallor, edema, lymphadenopathy.
Monica, you didn't discuss the other two symptoms.
Yes. And the next symptom is chorea. It was after examination, I'm supposed to say.
So all your conclusions is based on examination findings.
Yes.
Okay. Right. Whichever way you want to present, you go ahead.
Yeah, okay, sir. There is
Unless
no.
Professor Sivaji wants to interrupt.
Okay,
No, sir. No, sir. What do you say? Go ahead. Let her go ahead, sir.
Okay, sir. There is no pallor, edema, lymphadenopathy, icterus, clubbing, or cyanosis. Blood pressure in supine position was 123/63. Pulse rate was 90 per minute. Respiratory was 18 counts per minute. Thoracoabdominal. No neurocutaneous markers. Skull and spine were normal. No skeletal deformities or contractures. Central nervous system examination.
Any marker, any neurocutaneous mark specific?
No, sir. No, sir. Not present.
Yes.
Sir.
Yes.
And she's conscious. She was following minimal motor commands. The MMSE score was 20/30, and she is cooperative for a detailed higher mental examination. Behavioral observation: she is normal, she is emotionally stable, and she was cooperative. Attention: TAPE test was normal. Sustained attention was also normal. Language: spontaneous speech was present. Fluency was normal. Comprehension was normal. Naming, repetition were intact. Reading, she is not able to read because of her. She didn't go to school, sir. She studied till only 5th standard Urdu medium. Writing, she was not able to
What
write.
about the content? Content of the speech and reaction time?
Sir, it's normal, sir.
Okay.
Why did you say MMSE was only 20/30? What was she not able to do?
Sir, actually, I mean.
Now, what are the domains is deficient? You can say it would have displayed in the slides.
Yeah, sir.
So when you say about higher mental function normal.
No, MMSE 20/30.
Yeah. Sir, if I may intervene, sir. So she was not able to write, sir, because her right.
That you have to score all these deficit scores in the slides. It would be much better to know.
Yes, sir. And she was no formal education, sir. So calculation also was impaired, sir. So all this brought the MMSE down, sir.
And she was not able to copy the pictures of the involuntary movement because of involuntary movements. So all this have brought it down, sir. Digit backward and all this. She was
better, you would have put another slide in the deficit area in the MMSE score. Okay.
Okay, sir. And
so actually, there was no cognitive deficit. Am I right?
No, sir. No, sir. No.
Yeah, the impression given was that she was having cognitive deficit when you say MMSE is 20/30.
Sir, for her education, it was almost
appropriate.
Yes,
it was appropriate.
Yes, sir.
Yeah, that's important.
Okay. Sir. And lobar functions, frontal lobe, digit span, she was able to do like forward score was like 5, sir. Backward it was 3, sir. Clock drawing she was not able to do because of severe involuntary movements, sir. Motor luria she was not able to do. Design fluency, letter fluency was normal, but design fluency she was not able to do, sir. Go no go test with a lot of effort she was able to perform. Trail B test not able to perform, sir. Motor impasistence was present. Fixed edge palm test she was not able to do. Proverb interpretation was normal, sir, for her. And the recent memory registration was 3/3. Recall was 2/3. With cues, she was able to say like 3/3, sir. Remote memory, it was intact, sir. Semantic memory was also intact. Right parietal lobe, she was not able to cancel the targets among the distractors, and she was not able to bisect the horizontal line. She was not able to all these things because of her involuntary movements only.
Yes.
And she was able to locate the objects with respect to the patient. And constructional apraxia, she was not able to do because of involuntary movements and movements. Dressing apraxia also she was not able to perform as because now she's completely dependent on the caregivers. And topographical disorientation, she was able to ascertain spatial locations of objects, and she was able to recognize familiar landmarks also. Left parietal lobe, tool selection task she was able to perform, sir. Alternate tool selection task also she was able to perform. Gesture recognition task also she was able to perform. But pantomime she was not able to do it perfectly with lot of efforts. In spite of she having the involuntary movement, she was able to do so. And imitation of poses and sequences also she was not able to do so. And actual tool use also she was not able to do because of right upper limb involuntary movements only, sir. And limb kinetic apraxia was not present. Finger gnosis was present. Testing for right-left orientation, she was able to name the body parts being touched by the examiner, and she's able to execute the double-crossed movements on verbal command with lot of effort, sir. And she was able to name the body parts in the picture being touched by the examiner, sir. Occipital lobe, there is no visual field was normal, no visual agnosia, color naming matching and the color pointing were normal, sir. No simultognosia, and the letter translation she was not able to do, sir. Motor system, bulk, right arm, it was like 21 centimeters, left arm it was 20 centimeters, forearm it was 18 centimeters and the left was 18 centimeters, thigh it was 34 centimeters and the left was 34 centimeters, leg it was right side 25 centimeters and left side 25 centimeters. The attitude of the patient was like, patient is in supine position with left upper limb adducted, elbow was being flexed, wrist is being flexed, extended at metacarpophalangeal joints, flexed at proximal interphalangeal joints, and the lower limbs were crossed, sir. I'll be showing it in the following images. The tone was increased in all the four limbs, left predominantly more than right, sir. Formal power examination could not be done. And the plantar reflex was like right was flexor and the left was extensor, sir.
Why could not be power examination? Why could it not be done?
Because of severe spasticity, we were not. She was not, and she was not able to do so.
Even in the right limbs.
No, sir. Because of even in the right also she had spasticity, sir. But when compared to left, it was a bit lower.
She had movements on the right, sir. She had a lot of movements on the right.
Okay.
Will be displayed now, sir.
Okay. Okay.
And the cranial nerves, like olfactory nerve was normal, optic nerve, visual field was normal, fundus was normal, sir. Bilateral pupils were equal and were reacting to light. Third, fourth, and sixth nerves, like extraocular movements were normal, no nystagmus. Vestibulocular reflex was normal, smooth pursuit was normal, saccade was normal. Fifth nerve, sensory, it was normal, motor was also normal. Corneal conjunctival reflex were present. The seventh nerve, facial asymmetry was there, sir. Eighth, and I'll be showing it in the following images. Hearing was normal. Rinne's test, air conduction was greater than bone conduction. Weber's test, it's not being lateralized. Ninth and 10th, all the cranial nerves are normal, sir, actually. So superficial reflexes, corneal and conjunctival reflexes were intact. Abdominal reflex was normal. Right plantar was flexor. Left plantar was extensor, sir. The deep tendon reflexes.
Abdominal, you said NA. You put it as NA.
I mean, no abnormality was being found. Yes, it's normal, sir, actually. Sorry.
Yeah.
Deep tendon reflexes. On the right side, like the trapezius, biceps, triceps, supinator, knee and ankle reflex were present. Those are two places. But on the left side, all the reflexes are being exaggerated, sir. And there are no primitive reflexes, sir. But then there was ill-sustained clonus being present, sir.
Which side?
Both the sides. And sensory examination, touch and temperature sensations were intact. Posterior column sensations were intact. Hello.
No, the previous slide. Yes.
Romberg's test, it could not be tested as the patient was, bedridden in the state, sir. Cortical sensations were intact. Cerebellar signs, there is no nystagmus. Dysdiadochokinesia and other signs could not be elicited because of involuntary movements and severe spasticity, sir. Gait could not be tested as patient is completely bedridden. Extrapyramidal system, there's no axial rigidity, but there was like dystonia of left upper limb is being present, and there were non-pattern random distal greater than proximal involuntary movements of right upper and lower limbs. Rest of nervous system examination, no meningeal signs, sir, and other system examination were normal, sir. And these are the involuntary movements which patient had in the right upper and lower limbs.
Where is the ballistic movement, Amma?
So this is like typically right upper limb, there's a ballistic.
Yeah, I agree. Coriform movements
Yeah.
are there, but where is
Yes.
ballistic?
Ballistic will be different, no?
So intermittently it was
Yeah,
ballistic, sir.
but
This was, I think, taken after a dose of tetrabenazine, sir. Not intermittently, she had ballistic. She actually came to us readmitted for these ballistic. The movements had increased in amplitude, sir. From what we had seen previously, it has increased in amplitude, sir.
Okay, okay.
Video is not documenting that, but she had ballistic movements, sir, during the present admission, sir.
yes. Now, when we go to the symptom analysis, and there was a difficulty in walking that can be attributed
Do you have some more videos or only one?
only one video of the movements.
Okay.
And the difficulty in walking can be attributed because of spasticity of both upright, upper and lower limbs of both right and left sides.
Oh, you said she was dystonic. Can
Yes,
you show?
I have the image of that. I'll show you.
Yeah.
This is like left upper limb dystonia, sir. It's involving elbow, wrist, and even her like the metacarpophalangeal joints along with the interphalangeal joints.
Is she able to extend that limb at all?
No, sir.
No movement at all.
No, sir.
Is there any contracture?
Yes.
Yes, sir.
See, you said initially the picture seemed to be a motor involvement also, motor system.
Yes, sir.
You said a spasticity is present.
Yes, sir.
Along with this, he has dystonia.
Dystonia. Yes, sir.
Okay.
And there was,
Whether contracture is present only in the left upper limb, lower limb, or all the four limbs?
no, sir. Mainly the left upper limb it's being involved, sir.
Yes.
And there's a loss of right nasolabial fold also, sir.
What it indicates? What do you think of?
The asymmetry.
Yeah, you mentioned earlier also facial asymmetry.
Yes, sir.
How did you come to the conclusion? Did you check the movements, facial movements?
Initially, yes, sir. She had like initially when she presented with overall facial dyskinesia, I don't have a video at present, sir. There was like typical asymmetry, sir, with the weakness also, sir.
She had facial dyskinesias.
Yes, sir. Initially, sir.
That is when she was on DOPA.
Yes, sir. When she are being transferred from a government hospital to here, sir.
Okay.
And when it comes to the symptom analysis,
What is your examination of the seventh nerve says?
sir, apart from this asymmetry, it was completely normal, sir.
Facial nerve normal, huh?
Yes, sir. Only the buccinator mild weakness was there, sir.
Then where you will account this? Either a seventh nerve or some other area pathology. So what are all the muscles you tested seventh nerve?
Sir, we have tested.
See, 5 terminal branches are there in the seventh nerve, no?
Yes, sir.
So for all, have you tested all the 5 terminal branches?
Yes, sir. The frontal branch, temporal buccal branch, mainly the more weakness we found, sir. Yes, sir.
Is it due to a seventh nerve or some other problem?
Because of seventh nerve only, sir.
You have to say, because if you...
Yes, sir. Because it can be attributed to seventh nerve only, sir.
That means the seventh nerve is involved, partial facial palsy or a weakness.
Yes, sir. Yes, sir.
Or is it due to your dystonia?
Not due to dystonia is what I felt, sir. Maybe it might be dystonic also, sir, but there's a probability of it can be dystonic also, sir.
What is the difference between dystonia and how will you differentiate this weakness from dystonia, the facial muscles?
Sir, if I may intervene, sir, actually there is no significant facial weakness, sir.
Yeah.
It may be she had a lot of perioral movements, tardive movements she had during admission, sir, and it decreased after DOPA dosage. Maybe a soft sign. The facial weakness was not significant, sir.
Nirmala?
Nama, sir.
Nirmala, have you examined this patient?
Yes, sir.
What is your opinion?
So the facial weakness was not prominent, sir. It is more of a facial clonus was dystonia, sir. Initially, patient had a lot of tardive movements on when dopa was administered. It is more of maybe because of that she had the facial asymmetry, sir. But it was not very significant, sir.
Okay. She said some buccal involvement. Is it correct or not?
No, sir. No, sir. No, sir. Buccal involvement was not present, sir.
Okay. 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 Go ahead.
The final summary is like she's a 63-year-old female homemaker with no previous comorbidities, right-handed individual, presented with difficulty in walking, left upper limb abnormal posturing, and right upper and lower limb involuntary movements, which are insidious in onset, non-progressive, without any cognitive, sensory, cerebral autonomic dysfunction, without any significant family history. On examination, there's a bilateral spasticity.
Why do you say it was non-progressive? It has been progressing over the 3 years, isn't it?
Yes, sir, but yes, it's
yes, Professor Ravi sir is correct. You should say it's a progressive. Now it could be a static or for the past 3 years she was the illness was progressing one.
Started in the left lower limb, then the left upper limb, then right side limbs, and gradually she came to a state she has been bedridden.
Yes.
So it is a progressive illness.
Yes, sir, but okay, sir.
Now, what is your doubt? Please say. Why do you say it's not progressive? What is it that you are trying to say?
Don't get upset. It's a clarification we want from you.
Yes, sir, it's a progressive disease only, sir, actually.
Yeah.
Right.
On examination, there was bilateral spasticity, left greater than right, sir. Brisk reflexes, more on the left side, sir. And the movements were like non-pattern, random right upper and lower limb involuntary movements with right human facial weakness. And there's a combined segmental sustained dystonia involving left upper limb, sir. And the posture was like adducted, elbow was being flexed, wrist was being flexed, and it was being extended metacarpophalangeal joints and being flexed at proximal interphalangeal joints, sir.
So go to the previous slide, please. Go to the previous slide.
Okay, 1 second. Okay, sir.
Go to the Nirmal Kumar.
Yes, sir. Yes, sir.
Hey, she said now right UM and facial palsy. What do you say?
Sir, facial palsy, I feel it was not.
What I am saying now, she is told in the summary.
Yes, sir. She added in the summary, sir. Agreed, sir.
Yeah.
So
Even now,
they are confused. Whether
even
it's present
now,
or not, please.
Nirmal, even now, as she said, right nasolabial fold is flat.
Last.
Flat.
It says, sir, see the facial weakness. It's definitely, if at all it is present, is human, sir.
That's what she said. Yes,
that's what she said.
Yes, sir.
You said no, totally. There is no facial palsy. Normal.
She had mild asymmetry, sir, but I was not convinced of the facial. If at all
you have to again examine. You should not say superficially. There is in the picture. There is a obvious, clearly seen loss of nasolabial folded. It indicates EMN.
Yes, sir. So maybe because corticobulbar tracts are involved, sir, but the side was not correlating, sir. She had more symptoms on the left side.
Continue. Doesn't matter.
Okay, continue.
Yes, sir. When we go back to the symptom analysis, there's a difficulty in walking, sir, that we can attribute to the spasticity of both the right and left upper and lower limbs, left predominant than right. And it can be localized to bilateral corticospinal tracts above the level of pons, sir. And there's an abnormal left upper limb posture involving arms, elbows, wrist, hand. Probably there's a segmental dystonia, sir. And it can be localized to right basal ganglia and its connections, sir. And there's a chorea.
Monica, I want to clarify.
Yes,
you said the spasticity.
Yes, sir.
Spasticity mostly present in the
left side.
Motor system involvement. Isn't it? But the rigidity maybe the extrapyramidal.
Yes, sir, but there was no.
You said a movement problem, no?
Yes, sir. Sometimes we can even expect a movement disorder associated with dystonia also, sir, like in combined dystonias and.
Okay.
Yes, sir. And
sir, I want a clarification, sir.
Yes. We had both motor system involvement and external involvement, sir. Because the spasticity we say because it was only in one compartment, sir.
Yeah.
It was only mainly in the flexor compartment in the upper limbs and extensor in the lower limbs. It was not both compartments, sir. So essentially, our symptoms began with one side, which is more of weakness, sir. So there is definite corticospinal involvement, sir. And facial palsy may be attributed to that, sir.
Yes.
But when she came to us, she had posturing of left upper limb, which is not attributable to spasticity alone, sir. Because usually spasticity, we expect elbows, wrist, and sometimes contraction fingers, but this was more of dystonia, which started initially itself, sir. So spasticity is an endpoint of weakness, but she had posturing from initial onset of symptoms itself, sir.
So result from this, probably patient developed a motor weakness followed by involvement of extrapyramidal system.
As per history, she developed weakness first, sir.
Nirmal, does she have bilateral pyramidal spasticity?
Yes, sir. But
on examination,
was on the left side. On examination, she has bilateral spasticity, which was more on the left side than the right side, sir.
Okay, right. With involuntary movements on the right side, yes, and sir, possibly a dystonic posture at onset on the left upper limb.
Yes, sir. With the movements, concerning the movements, sir, it was definitely coriform movement, sir. So initially, we thought it was triggered by syndopa, sir, levodopa, sir, because they had started levodopa in view of rigidity. That was our thought process, sir.
Yeah, correct.
So what we did is we cut down on the levodopa dose and started tetrabenazine for the movement, sir. But currently she is on a minimal dose of levodopa, sir. She is currently on only half BD.
You are still continuing levodopa?
Minimal, sir. Very minimal, sir.
Why?
We are in a tapering process. Half BD only she is taking. But even now she is having movements.
Correct. But why are you continuing levodopa?
Sir, we wanted to stop. So we'll stop next week. So she came to us 2 weeks back, sir. So the process of stopping. And sometimes when she stops levodopa, or dystonia worsens, sir. So
what happens to the chorea?
Chorea is subsiding with levodopa, sir. But recently,
subsiding with levodopa?
No, sir. I mean, when she was tapered of levodopa, it initially subsided, sir. But recently, even at minimal levodopa, sir, she's having a lot of movements, sir. Now, the video played was 1 week back. She had ballistic movements as well, sir. So half BD dose of levodopa caused such movements, sir.
No. When you stopped that, even that half, what happened?
We didn't stop it, sir.
You not stopped and seen. Okay.
Yes, sir. But our current thought process is that it was not only levodopa induced movement, sir. There was a coriform movement which was present, which was triggered by levodopa.
Okay. Right. You are the best judge. Okay.
Yes. And when it comes to the differential diagnosis, we can take into consideration of Wilson disease, sir. I'll say the for and against points for the differential diagnosis in the coming slides, sir. Corticobasal degeneration can be kept in mind. Huntington disease, phenocopies, and pallidopyramidal syndromes the complete blood picture was normal. Peripheral smear was normal.
One second. We also consider a lot of reversible paraneoplastic syndrome, sir. But the patient was not initially affordable for the paraneoplastic workup. But we are counseled them, sir. They will probably be doing it the next week, sir. But the duration was longer than what we expect in the paraneoplastic. It was 3 years, sir. So any chorea more than 1 year, we should consider genetic causes is the conventional teaching, sir. So we consider Wilson's and more of degenerative is what we have considered now. Paraneoplastic we have planned, but patient is not affordable as of now, sir.
Okay.
Yes, sir. And the peripheral smear, it did not show any acanthocytes, sir. Renal function test, liver function test, ultrasound, serum electrolytes were normal. Viral markers were negative. CT chest and CT abdomen were normal, which we have done in view of paraneoplastic thing, sir. 24-hour urine copper level was less than 50 micrograms. Serum ceruloplasmin level was 25 mg per deciliter, which was normal. Whole exome sequencing is being sent, sir. The report is being awaited. Paraneoplastic panel is not being sent due to financial constraints, and the MRI brain is being done, sir. Here we can see there's a evolutionary atrophy along with the caudate nucleus is being preserved well, sir.
Nirmal.
Yes, sir.
In your institute, do you have a PET CT?
No, sir. No, sir. We sent to no, we don't have it. We outsource it, sir. We don't have it in our institute, sir.
Okay.
And she's not affordable also, sir, for the PET CTs. Yeah. We are being counseling her. And when it comes to the discussion,
sir, MRI, show the MRI again, Monica.
Yes.
Do you explain anything? Is there?
Nirmal?
Yes, sir.
No, you were in your differential. You were mentioning Wilson's.
Yes, sir.
What about disorders of iron metabolism?
Yes, sir. We considered that also. Pallidopyramidal syndromes we are considered, sir. But MRI normal, sir.
No, MRI is coming only now. But before that, I'm asking.
Yes, sir. She had mentioned, sir, pallidopyramidal syndrome, sir. Now NBA mostly comes under the palliatopyramidal syndromes, NBA group of disorders. It's considered as a differential, sir.
Okay. Okay, now come to the MRI. Oh, wait.
Yes, sir.
You said something about the MRI? You said something about the caudate?
It's being well preserved, sir.
Okay.
Yes. Hello.
Continue.
Yes, tell me for and against points. Yes, go ahead, Monica.
Maybe some technical issues, sir. Give me 2 minutes, sir. I'll just.
Okay.
Technical glitch, sir. She's fixing it, sir. She'll be back in 2 minutes, sir.
Okay. Meanwhile, if others want to comment, they can comment. Sivaji sir, you can ask the people to comment.
I think they have to say any other investigation.
They just have to unmute those who are listening can unmute and make their comments.
When, sir, you can.
சொல்லுங்க.
You can tell, sir.
Well, now of course, I would probably consider, as I said, ultimately it's going to come to genetic testing.
Yes, sir.
But my first diagnosis would probably be abnormal iron accumulation. I would go into that.
Sir. It could be, sir. Otherwise ruled out.
But MRI is not contributing to that.
Not contributing.
Yes.
And
so that is why they are presenting.
Sir,
yes,
actually, if I may speak, sir.
Please.
Yes,
sir. When the patient came to us, sir, initially our thought process was more like a corticobasal syndrome, sir. Because we had unilateral dystonia with unilateral weakness, both of which are quite possible in a corticobasal syndrome. Her age also was fitting with the what we expect in a corticobasal syndrome, sir. But we expected her to, initially there was no sensory involvement, there was no AST diagnosis or graphesthesia. So there were not much of cortical signs, so more of subcortical was what she had. So when she developed a levodopa dyskinesia, we assumed it was due to degeneration in the basal ganglia, which triggered the dyskinesia. So initially for 6 months, we are managing her like a corticobasal syndrome, sir. So what made us think of alternate diagnosis is that there 1 year into she first came to us, she didn't develop any cognitive impairment. She didn't develop any cortical sensory signs. So there is still no cognitive impairment, still no cognitive sensory, loss of AST diagnosis or graphesthesia left over was not present, sir. So this made us think of alternate diagnosis, and since chorea became more a prominent clinical picture now, so we were prompted to think of other etiologies except the corticobasal syndrome. So when we were, sir, yes, sir. Yes, sir.
Yes, sir.
Yes, sir. Sorry, sir. There was a technical glitch, sir.
Okay.
Yeah.
Nirmal?
Yes, sir.
Yeah.
What is your? You continue, please.
So we went through literature, sir, to look for other pallidopyramidal syndromes.
Yes, sir.
Obviously, Wilson disease we ruled out at the onset itself. So coming to other pallidopyramidal syndromes, NBA was what we came through. But NBA, the documented age groups are not more than 30-35 years, sir. So the age
we have late onset NBIs, no?
Yes, sir. Yes, sir. True, sir. True. Agreed, sir. But MRI normal. So with the normal,
Yeah, that
it wasn't quite fitting, sir.
Okay.
We also thought of Huntington's phenocopies. So Huntington's disease, we also sent the workup. It is awaited, sir. So other Huntington's phenocopies like chromosome 9 over of 72 mutations, which is quite common in Africa, not here. SCAR 17, but there is no ataxia at any time during the illness. And HTL2, it's also a phenocopy of Huntington's. And
the cognition is intact.
Yes, sir. Cognition is intact, sir.
That's a bit unusual for a...
Yes, sir. Huntington's has case reports of not having cognitive impairment, presenting with weakness, pyramidal involvement.
But not this much of spasticity then.
Correct, sir. Correct, sir. Correct, sir. Correct, sir. So that's why we wanted to open of the forum how to proceed with this case, sir. We have done everything in our means, actually, except for the paraneoplastic workup.
No, what about the genetic studies?
It's awaited, sir. Sent, sir. Awaited, sir.
It takes 4 weeks of time to get the reports.
It's awaited, sir. Yes, sir. Sir, not audible, sir.
Shivaji is not audible.
Oh.
Now it's better, right?
Yes, sir.
Better. Sir.
Yes, sir.
Yes.
See, there is a family history of cardiovascular disease. 2 people have died.
Yes, sir.
This patient also developed why don't be a vascular etiology, and the patient developed initially a weakness left side.
Yes, sir.
And then movement problem.
Sir,
can you attribute a vascular problem to this?
No, sir. It is progressive, sir. It is not a static or maximal onset static sort of illness. It was not like that, sir. It is progressive illness. The weakness was itself progressive, sir.
Okay.
So,
okay.
Vascular causes, we didn't consider it initially, sir.
Okay.
Monica, can you present now?
Yeah, sir. So the 4 points for Huntington disease, usually there has to be like a GPS3 mutation, so the animation is not being played. And the against points here in our particular cases, there is no cognitive impairment and there are no psychiatric manifestations, and there is absence of family history also. And even the Wilson disease, here the against points are like the age of onset and the workup was completely negative, sir, and there was no the case of flesh shedding being seen, sir. And corticobasal degeneration, except for the asymmetric dystonia, it was not being fit into the criteria, sir. And there was no cognitive impairment and the cortical motor sensory features were absent for her, sir. And
no apraxia also?
Nothing, sir. Nothing, sir. And we can think of like Huntington disease, like, there are phenocopies, all these things, sir. But the against points, sir, she's a Asian descent, she's not African descent, and there are no psychiatric or cognitive features, and there is no caudate atrophy, which is being shown in the MRI, sir, which is typical for Huntington disease, like. And the pallidopyramidal syndrome, we can think of like NBA spectrum of disorders, sir, but the age of the onset and the absence of psychiatric manifestation and the normal MRI imaging, it makes it unlikely, sir. And the other possibilities, it can be like complex HSP, we can think, sir, but severe upper limb spasticity and the age of onset again makes it unlikely, sir. So, yes, sir.
HSP can... HSP infection even can happen in a advanced stage also.
Yes, sir. But usually HSP will have lower limb weakness, prominent weakness.
Oh, it's not an upper limb.
This is usually not common in HSP, sir. So overall, we don't know what it is yet now, sir. But we have seen the genetic workup. We just want the opinion of the forum on how to proceed with the case, sir.
Yes.
Yes.
Any other DDs to be considered apart from what we have considered, or how to take it forward is what we want from the forums.
So, among the genetic and autoimmune,
we consider paraneoplastic syndrome, sir. But the genetic we could do via insurance, sir. We had the provision to do it via insurance, so patient was not affordable, so we did via insurance. But paraneoplastic, she needs to pay the money, so she said it will come back. The screening malignancy was negative. PET CT we didn't do. And workup for paraneoplastic antibodies are yet to be done, sir. That is the only thing which is pending.
So what are the paraneoplastic? What are the things you, because already you have ruled out the para except the panel, but
Yes.
CT abdomen
Yes,
and
sir.
chest
Normal.
as a clear.
Yes, sir.
If at all,
Anti-Hue could present with the chorea. Anti-Hue and anti-CRMP are the two things which should present with the coriform disorder.
okay.
So, and those two are what we expect when we send a workup, sir. But we are yet to do that, sir.
Contributions from others? Anybody wishes to discuss? Anybody wishes to contribute?
Just a small questions. Small questions. How long is the duration, sir?
3 years.
3 years.
Okay. So a couple of things. This is a very nice case, sir. I agree with them that Wilson's is a possibility, and duration
Wilson
initially.
ruled out, sir.
Yes, sir. Yes, sir.
No, let him discuss. Let him discuss.
Okay.
Yeah, I told them what all the discussions are Wilson's, the Huntington's and all. So the possibilities, just I want to have PGs and other things. Initially, like as they thought that corticobasal syndrome can mimic like a Parkinson's, they can have a chorea, they can even have a motor fluctuation response to levodopa will be very good. But over the years, 3 years is a good time, they will develop a resistance to levodopa. And a couple of things I was thinking. So one, the response to the levodopa was something was there initially. Dystonia was worsening. There is a chance. There are two things. One, dopa responsive dystonia can have this type of dyskinesias, response to levodopa, chorea, motor choric movements can be there, and the NKX2 gene can be there like this. But அது வந்து late onset very very uncommon, sir. So அதை வந்து நம்ம வந்து consider பண்ண வேணாம். Late onset போது the possibility of a Huntington's and dentatorubropallian leucine atrophy plus a DRPLA, other possibility. Any possibility of C9orf also a common cause நம்ம பார்க்கிறோம் சார் regular. So any ataxia was described in the family,
No.
sir?
No, sir.
No ataxia earlier.
No,
So
sir.
so அப்படின்னாக்கா இந்த SCAR 12 and 17 அதெல்லாமே நம்ம வெளியெடுத்தலாம் நம்ம. Other thing is family history of வந்து there is a strokes are there. The possibility of how is the hemoglobin, any polycythemia was there?
Nothing, sir. They were
Okay. So
nothing.
usually வந்து the recurrent strokes எல்லாம் பார்க்கும்போது we always think about polycythemia rubra vera. That is very very common with the chorea. And also people with the antiphospholipid antibody syndrome, SLE can present with recurrent stroke. So these all the late onset very often we see this one. And how about acanthocytes?
No, acanthocytes are being seen in the peripheral smear, sir.
Any peripheral neuropathy was there for the patient?
No, sir.
Okay, NCS was normal.
Yes, sir.
Okay. NBIS on the late age group very very uncommon, but still we see rarely. But late onset like a plan can present like almost mimic like a Parkinsonism. The response to levodopa will be there. MRI can be negative also. It is CJD anything, but 3 years is a longer period.
But CJD usually they'll have a rapidly progressive disease.
3 years is a longer period.
Yes.
Yeah, but as Sarah's mentioned, other things வந்து பாத்தீங்கன்னாக்கா autoimmune and paraneoplastic. Iglon 5 is one of the commonest which
but there
can
were
present
no
like
sleep disturbances and even the duration of age which was not being fitting into this Iglon 5.
like Iglon 5 we see it in later onset also. But என்னன்னாக்கா 3 years is a rapid longer duration for Iglon.
Yes.
Even for autoimmune வந்து பாத்தீங்கன்னா as we told that NMDR or Casper can present like this type of chorea, but 3 years is a longer period. And paraneoplastic also CVT எல்லாமே வந்து it's a longer duration. So these are all the possible differential diagnosis I was thinking, sir. So do you think anything else, sir?
Any others want to give opinion from the forum? Nadesan sir, you're on the line.
Justin இருக்காரு, முகுந்தன் இருக்காரு.
Yes, Mukundan, Justin, they can contribute and they can.
விஜயன் இல்லைன்னு நினைக்கிறேன். ராமகிருஷ்ணன் இருக்காரு.
ஆமா, ராமகிருஷ்ணன் சார். ஒரு சீனியர் பர்சன் யூ கேன்.
சார் பட் எனக்கு
மேகண்டன் சார் இருக்கதா? சார் ராமகிருஷ்ணன் சொல்லுங்க
சார். இல்லைங்க சார், விஜய் சங்கர் டோல்ட். ஆனால் ரொம்ப கன்ஃபியூஷனா இருக்குங்க சார். இதுதான் சொல்ல முடியற மாதிரி இல்லைங்க சார். அண்ட் எவ்ரி திங் தே இஸ் ரூல்ட் அவுட் ஆல்சோ. பட் தெரியலைங்க சார், அதனால தான் எதுவும் சொல்றதுக்கு அது மாதிரி இல்லைங்க சார். இட் இஸ் ஒரு கிளாரிட்டியா இதுதான் சொல்ற மாதிரி இல்லைங்க சார்.
எக்ஸாக்ட்லி, தட் இஸ் வை தே ஆர் பிரசன்ட்.
மேகண்டன் சார் இருக்காரா?
சார் இருக்கா சார். சார் ஐ ஆல்சோ திங்க் I'll just think back again. Insidious onset, slowly progressive weakness of the left upper and lower limb. Lower limb initially, followed by left upper limb, and developed abnormal movements on the right side.
Yes, sir.
And there was little confusion about the right side, the upper motor neuron facial palsy, and right hemiparesis, or right upper motor neuron facial palsy with the left hemiplegia you don't get generally.
Yes, sir. Yes, sir.
My professor used to say that when somebody gets extrapyramidal symptom, if he develops a stroke, the extrapyramidal symptom will disappear. And here it has come both together. And it is again very fishy. And probably somewhere where something is lacking, either in the history or in the examination itself. It was again the dystonic part, which we see any neglected hemiplegia. They go for, especially in infantile hemiplegia and other types, when the patient is not getting treatment of physiotherapy or neurorehabilitation. The hemiplegia itself may go for dystonia. We used to call previously as pyramidal dystonia. Like that.
Dystonia, Megan sir, maybe
yes,
what you said, dystonia. Chorea is present.
She developed the chorea on the opposite side.
Yeah.
All that we know is an abnormal posture of the left hand.
Yes.
We do not
abnormal posturing of the left hand is because of the neglect of the left hemiplegia itself.
Left hemiplegia for a long time.
Yeah,
possible.
So that looks mainly like a contracture rather than the dystonic.
Yes, contracture rather than the and also yes, a definite faintness right side.
So what is the history? What does the history say with regards to, you said, an abnormal posture of the left hand that developed quite early? Yes, what did they describe? Monica.
Sir, actually, they were just aware that she's not able to do her daily core activities. The pace got decreased just because of the restriction of the movements, is what they told, sir. I mean, because of the abnormal posturing, sir.
Yeah, what was the abnormal posture?
Posturing means the weakness or a posturing, because the dystonia part came later.
Yes, sir. Weakness.
First you said a weakness, first distal and the proximal weakness, as you told in the history.
We didn't think of the vascular cause because it was not that high.
No, Monica, apart from what you thought of,
yes,
you first define what was the abnormal posture that they described in the early part of the disease. What was the, because now we are at almost, it's very difficult to conclude, as you saw, whether it's a dystonic posture, whether it is contracture. But you said right from the beginning, left lower limb weakness and left upper limb abnormal posture. Now, what was the abnormal posture that they described?
They described like left upper limb. Initially, it started with the hands, sir. I mean, the interphalangeal joints and the metacarpophalangeal joints, and then it progressed till the elbow level, is what they told us.
No, but what was the posture like? She was able to do activities with that limb.
Initially, she was able to do, sir, but
how did it interfere? That posture, how did it interfere with the functioning of the left upper limb? Did it interfere with the function of the left upper limb? Did it interfere with other functioning? What?
I mean, the daily core activity she was not able to do, sir. Initially, what they observed is left lower limb only, sir. And
no, forget the left lower limb. We are discussing only the left upper limb. You are throwing in a lot of differential diagnoses. You say it's a corticobasal syndrome. you based it corticobasal, you brought it because of the left upper limb posturing.
Yes, because of like combing and the gripping of objects.
Yeah, you'll have to say what was the difficulty. Was it weakness? What is abnormal posture which interfered? Did that abnormal posturing interfere with the functioning of the right upper limb? What? See, we are at the end stage now, so it becomes difficult for us to control.
The thing is, it was not weakness, because initially she was able to hold the objects in place, but then there was a occasional dropping, sir, because of the posture. She was not able to sustain them, sir. Actually,
see, the object dropping clearly says a weakness. It's abnormal movements and all.
so in weakness, we'll not be able to hold the objects. No, sir.
Do you have any description? Do you have any photos? Do you have any videos of her previous?
Because she have come to us like very recently, sir.
No, she had come to you, but she would have gone for treatment elsewhere. No, you said she was started on Syncopa elsewhere.
In a government hospital, sir.
Yeah, what was the findings in the government hospital?
They would have given discharge summary, no? Even the government hospital, mostly in the neuro, I think neurologists must have been seen the patient. Is any patient admitted in a government hospital, medical college, they would have given a discharge summary, examination findings.
Patient had only she carried only notebooks, so no discharge summary, sir. Which had only. Stanley, sir.
Stanley na paka kundurpalaba.
Sir, admit sir. Patient was never admitted, sir. Sir. She was only OP basis treatment, sir. She had a notebook which said Syncopa, sir, which she was on Syncopa.
No, but what was the description of the findings, sir?
They didn't mention in description findings, sir. As per history, she initially, as she mentioned, lower limb weakness followed by upper limb weakness, but they said the upper limb went for intermittent posturing at the onset of disease itself, sir.
Adana, that is what we need for the discussion. See, we need to know what was it. If a discussion, as you find, is between dystonia and spasticity.
Sir, she definitely had dystonia at the onset of symptoms itself, not the end stage of symptoms, sir. That is very clear.
Like he had left hemiparesis or not? Left hemiplegia?
Yes, sir. Yes, sir.
He had left.
But it was not a stroke, sir. It was a progressive weakness over the past 3 years.
Nirmal Kumar,
yes,
was it a left hemiplegia?
Sir.
Or was it a difficulty with the use of the left lower limb and left upper limb? That is not equivalent of left hemiplegia. And that's why we discussed at the history stage before you came to the findings. What did it mean? It could have been anything. It could have been an extrapyramidal problem. It could have been a pyramidal problem. It could have been a lower motor neuron problem. It could have been a cerebellar problem.
When we correlate with what findings she had now, because she had no.
Yes. So correlating with that, what do you think is the left upper limb? Is it an extrapyramidal right from the beginning? Was it abnormal?
Not only extrapyramidal, it is both pyramidal and extrapyramidal, sir. Because she has spasticity.
Forget pyramidal. Was there an extrapyramidal component which started as an extrapyramidal component? Then why do you bring in corticobasal? If it was only pyramidal, what was the need for you to bring in corticobasal?
She had both pyramidal and extrapyramidal, sir.
That's what I'm saying. So the question of corticobasal itself came in because of that abnormal posture, which you have been calling as dystonic posture.
Yes, sir.
Now that there is a discussion on whether it is a dystonic posture or whether it is only spasticity. Right at this moment where you showed the video, it's very difficult to say because we do not see the posturing at all.
Yes, sir.
But if you go by the history, it looks like she had a dystonic posture.
Yes, sir.
Isn't it?
Yes, sir.
So then the discussion will be a little different. The differential diagnosis would be different. If she had a dystonic posturing, then obviously she had pyramidal sign, she has dystonia, she has chorea. Chorea seems to be lateralized to the right side, while the dystonia seems to be on the left side. So we would have to think of these problems, and yet the MRI does not show any abnormality.
Yes, sir.
So that is where we stand. This upper limb posture has to be sorted out. That has to be made very clear whether it was dystonia or not.
But spasticity cannot be contributed to upper limb because usually in spasticity the sleep will be disrupted because of spasms.
We are not talking of usual. We are talking of this patient.
Yes, sir.
Based on the history, discuss this patient's problem.
So from the history she collected, she had both evidence of weakness, pyramidal plus extrapyramidal, sir.
No, first of all, I am not convinced. What pyramidal? How do you say pyramidal right from the beginning?
There's history of weakness, sir. She was not able to put the lower limbs on the bike.
On the
Bike. She was not able to mount the lower limbs because of weakness. She was not able to lift the.
No, but how do you conclusion it was weakness? See, she was not able to put her left leg across the bike.
Yeah, but my initial
that
stage
can happen in a number of situations. It can happen with lower motor problem. It can happen with an upper motor neuron problem. It can happen with the corticospinal. It can happen with the extrapyramidal. It can happen with cerebellar. All these can have problems with crossing the leg over the bike.
Yes, sir.
Yes.
Now that we have a clear-cut left plantar extensor.
Hypertrophy. Right, you are now okay. Yeah. You are extrapolating based on the present findings, right? We are only discussing on the past what she had, whether it will throw some light into the base of the problem, nature of the problem, right? Okay, now it's different. That's why past documentation of the findings, if it was there, it would have, it's not there. If it was there, it would have been helpful, right? Okay. Okay, continue. Whatever you have, some more you present.
So let's investigate completely, and then you can present the next meeting.
Sure. So at present, we are not able to come to any conclusion. Yes. I would still consider it as, see, even if you consider corticobasal syndrome, it's not a full-fledged picture of a corticobasal syndrome. Right, Nirmal Kumar?
Yes, sir. That is why we are considering alternate.
There is no cortical finding at all.
Yes, sir. Yes, sir. That is why we are considering alternate diagnosis and want the
yes, sir. Whole thing is subcortical. Yeah.
Now, what is your
Professor?
What is your provisional diagnosis?
Sir, to be honest, we don't know, sir. It's a pallidopyramidal syndrome, sir. Pyramidal plus extrapyramidal.
Okay, agreed. That much, yes. Okay, we'll see. I think genetics may give a clue. And have you measured ferritin levels or anything like that? Does it help?
Ferritin, no, sir. We didn't measure, sir.
Okay, right. Okay, if there is nothing else, fine. Sivaji sir, can we proceed to the next case then?
Yes, sir. We can proceed to the next case, sir.
Yes. Recurrent encephalopathy.
Yes, sir.
Thank you so much for this opportunity.
Thank you, Monica. Thank you for presenting a nice case. You stumped all of us.
Yes. Yes, next case. Karthik Amara. Yes, Karthik Amara can proceed.
Sir, your voice is not audible, sir. Your voice is not.
Yes. Not audible. Karthik. No, your voice is not audible, ma.
Hello, sir.
Yes. Go to the first slide, please.
Okay, sir.
Yes.
Sir, October 10, 2023, a 60-year diabetic female, teacher by occupation, presented with 3 months onset of headache, subacute onset of headache, worsened headache, intense continuous not able to sleep, suicidal intention because of severe pain, unilateral right-sided headache, sir. The headache is not associated with any tearing, no redness, no congestion, no diminished visual acuity. It is also associated with small joint pain and stiffness. The headache is associated with severe jaw claudication while eating, while drinking cold water and everything. There is also the scalp tenderness over the right temporal region. At that time, fundus examination disc margins were clear. Rest of the neurological examination was unremarkable. So we suspected giant cell arteritis because in this 3 months of duration, she had multiple outside visits where he treated as migraine and everything, but there is no change in quality or severity of headache. We suspected giant cell arteritis because the patient has elevated CRP 213 milligrams per liter and ESR 120, sir. The total leukocyte count is 120. Because of suspicion of giant cell arteritis, we advise you use the superficial temporal artery, which seems to be normal. There is no halo sign. Temporal artery biopsy could not be.
Yes. Your voice is breaking, please. Not audible.
Temporal artery. Sir, am I audible, sir?
Yes,
You are
you're
audible. You are audible.
Sir, temporal artery biopsy could not be done due to patient is not willing. So we plan to start injection methylprednisolone 500 milligrams because he is diabetic and should prevent complications. We started with 500 mg methylprednisolone. After giving first dose, she has a dramatic improvement in headache. So we completed another 4 doses of methylprednisolone. We discharged with oral prednisolone 60 mg per day for 1 week with a tapering of 10 mg per week over total 6 weeks. And we added methotrexate 7.5 mg weekly simultaneously for steroid sparing. So all went well for next 3 months. She don't have any headache episodes. No, there is no blurring of vision for next 3 months. On February 18, 2024, 3 months from the last admission, patient had fever for 5 days, altered sensory for 2 days, decreased food intake for 1 week. History of present illness, patient presented with high-grade fever with chills. This time there is no headache or arthralgia, there is no neck pain, there is no jaw claudication, nausea and vomiting. There is fever followed by altered sensory for 2 days. Altered sensory in the form of irritability, anger outbursts, and irreverent talk. She was confused and behaved as if she was working at school when she was at home. There is no hallucinations at this time. There is no involuntary movement.
Altered sensory in the form of irritability, anger outbursts is an emotional problem. It's a big emotional problem. It's not altered. Altered sensorium should be a attention or a sensorium consciousness will be lost. No.
There is, she is drowsy and there is
the irritability, anger outburst is a behavioral aspect.
Okay, sir.
Isn't it?
Okay, sir.
Don't talk other things is altered speech and all.
She has altered sensory along with irritability, anger outbursts, and irreverent talk over the past 3-4 days, sir. And there is no hallucination. There is a decreased food intake. On examination, pulse rate 120 per minute, BP 120/70, respiratory rate 18, temperature 100.34. Saturation was normal, sir. She was conscious but disoriented to time, place, person. Not cooperative for mental stress examination. MMSC could not be done because of altered sensorium. Cranial nerves are grossly normal. She was able to move all 4 limbs and walk without any support. She was not ataxic at that time. There is no slurring of speech. No obvious extrapyramidal signs. With the history of GCA now present with acute onset of altered sensorium, we initially start off because of preceding inflammatory headache. Now with altered sensorium, we suspect of acute sinus infection, encephalitis, and also we suspect of any other form of septic or metabolic encephalopathy. So we proceeded with MRI brain, CSF analysis apart from routine workup. Empirically, because of thought of encephalitis, we started on ceftriaxone, vancomycin, aceclomycin, dexamethasone, along with other haloperidol injection. She was restless and agitated. At this time, we withheld methotrexate because of concern about septic encephalopathy. This time, she is having WBC count of 60,500, neutrophil predominant. At this time, LFT, RFT, rectomites are normal, viral markers are negative. CRP 314, ESR still 114, still elevated. We done MRI brain with contrast. It's showing is normal except mild gliotic change in the right temporal lobe is related atrophy. CSF analysis shows cell count of 2, protein and sugar within normal limits, ADA within normal limits, gene expert normal, HSP PCR 1 and 2 negative, cytology HLS clear. Urine culture reveals capsular pneumonia. We thought of having urosepsis. We treated accordingly. This is MRI of the patients. MRI gradual except mild gliotic changes in the right temporal lobe. A patient improved symptomatically about the treatment, become oriented to time, place, person, discharged with oral medication and diabetic medication. In view of old gliosis and small vessel changes, we started with antiplatelets and statins. So we thought of it is due to septic encephalopathy secondary to UTI recovered. She discharged, she is doing well at home. 3 months later, June 4, 2024, she again admitted with altered sensorium, behavioral changes, and hallucinations. History of present illness. Patient was since 1 month, again, she developed altered sensorium and behavioral disturbances.
What is the
Sir.
hallucinations, visual or auditory hallucination?
She is having both visual and auditory hallucinations.
You have to describe. So first person, or second person, third person hallucinations?
Second person hallucinations, sir. Next slide, it is having hallucinations.
You are describing. Next slide. Okay.
She developed altered sensory in the form of disorientation, aggression, anger, bursts towards past 1 month. This time she is having no fever, no headache. She is also having behavioral changes in the form of unconcerned mixation, talking to relatives even though they were not there. She also repeatedly told her husband that she wanted to commit suicide because it was instructed by some other person outside. She is hearing voices that someone asking her to commit suicide.
The voice, sir,
also
voice telling.
Sir?
A commanding voice or a commanding voice?
Commanding voice, sir.
Commanding. Who is that commanding? A group of people or single people are commanding?
He's always saying single people, visual
have you asked clearly? Don't say roughly. If you recorded, you would have thrown all these things in clear. So commanding voice or commenting voice?
Yes, sir.
So you have to say, you have to explore the history as is wished, social intention, social thoughts. It could be auditory hallucination, commanding nature, or a commenting nature. The third person or for the second person hallucination, you should clearly reveal here.
Okay, sir.
Yes.
She also had some form of executive dysfunction, unable to tie sari, difficulty in all other routine activities, daily activities.
How old she is?
60 years, sir.
60 years.
She is disoriented, sir. This is irrelevant talk.
Can you able to comprehend the content of thoughts or what's he express?
Sir?
Can you tell what she's telling in the video, Karthik? As the voice is not audible here.
Karthik.
Repeatedly. Sir. Sir, she is repeatedly saying what I can do, what I have to do, what I can do. Enna pannadu, and she is asking.
Asking you or she is talking on her own?
She is talking on her own, sir. But whenever we are asking questions, she is repeatedly like preservation. She is saying what I can do, what I can do.
What is polylelia? What is echolalia?
Echolalia is repeating the same words what examiner is asking.
Okay, go ahead.
Sir, this time an examination not cooperative. This time also this is not cooperative for higher mental function examination. Poorly attended delays. Cranial nerves drastically normal. This time also able to move all 4 limbs. The present status is same like the last admission, sir. Not ataxic, not flaring, no obvious extrapyramidal signs. This time we again repeated CBC, LFT, RFT, electrolytes, blood and urine cultures were normal. CRP still elevated 354. This time during hospitalization, she developed new onset generalized tonic-clonic seizures for which she started injection levetiracetam 1 gram BD. We repeated EEG. which is showing theta range background slowing without any epileptiform activity.
Where the levetiracetam started in your hospital?
After third admission, sir, where she came with behavioral and behavioral disturbances.
When the patient has got a behavioral problem, be cautious about starting levetiracetam. That will aggravate or increase the confusion state as well as the suicidal thinking psychosis.
Okay.
The people should be very careful when the patient has got a psychiatric background or a depression or suicidal thoughts. Levetiracetam still works, and you would prefer some other AEDs.
Okay, sir.
Okay. Sir. Yes, go ahead.
EEG theta range activity without any epileptiform activity. So this time again she came with second time altered sensorium, elevated CRP. This time even in the absence of infection, recurrent encephalopathy. Now she had one episode of seizure with structural MRI lesion, small right temporal gray axis. Whether it is contributed to the seizure or not, we cannot point out at this time. So this time we thought of autoimmune encephalitis, sir, because of recurrent encephalopathy. So we advised the patient CSF autoimmune profile and other paraneoplastic factors. This time patient husband is not willing because of some affordability issues. So we empirically started with methylprednisolone 500 mg IV for 5 days. Autoimmune encephalitis panel and serum TP, anti-TP, anti-thyroglobulin also sent, sir, to rule out steroid response to encephalopathy with autoimmune thyroiditis.
What was the result? Anti-TPO?
Next I'm telling, sir. Anti-TPO, TG titers, TFT are normal. So we had autoimmune encephalitis also we advised, but this patient is not willing the CSF test this time. So we empirically started methylprednisolone. On second or third day only she is sensorium improved. Still mild disorientation was noted. Aggression and restlessness was reduced. She able to dress herself and she is to execute other activities on herself. After 1 week, she was discharged with oral prednisolone 60 mg per day for 2 weeks with slow taper along with azathioprine. Because of we suspecting some autoimmune etiology, we started with an azathioprine. Anti-TPO, TG titers are low, TFT is within normal limits.
Low titer, anti-TPO?
Low titers are less than 9.
Okay. Your audio is not audible.
Can you increase the volume, Karthik?
Yes. Or you can...
The volume of the video.
Audible.
It's not audible. You can say what she said. Yes, Karthik. Proceed.
Sir?
You can tell what she says.
Nirmal, have you seen this patient? You can tell her.
Sir, actually, I saw the patient, sir. Actually, I was inquiring her about her well-being, sir.
Okay.
Whether she's good or not. She said, I'm not doing well.
Person, sir. She's telling what?
Okay, proceed.
Karthik, I will tell. Karthik, I will tell.
We asked about place. She's well oriented to time, place, person, sir. She's recognizing all family members and telling the names of all family members. She is able to do all the activities on her own. So we discharged the patient with oral prednisolone and azathioprine, sir. So after discharge, 3.5 months later, fourth admission on September 27, 2024. She readmitted for altered sensory for first 2 weeks. She had altered sleep patterns, awake at night, sleeping in the daytime, and the same agitation, anger outbursts, irrelevant talk, decreased oral intake as in previous admission, and even worse. She had a lot of delusions that someone planning to kill her, someone instructing to suicide, same as last time. There is no fever, there is no seizures at this time. She is on tapering dose of steroids, 20 mg prednisolone. This time, her husband also complaining of generalized tremulousness and generalized wasting. His vitals are within normal limits. She could not walk at this time.
Bladder bubble?
Sir, during the after she went home in the period of 3 months, she's a normal bowel and bladder habit, sir. Whenever she started ultrasensorium, she's coming to hospital. She's urinating in the bed. We are catheterizing the patient. Hello, sir.
Yes.
Okay, play the video. Play the video. Karthik, you can describe what she's telling in the video as the audio is not audible.
What she's asking, she's telling what I can do, she's telling. Enna pandrathu, she's telling.
That looks like a relevant speech, and she is worried about her illness, like that, you know. Her
Yes, sir,
insight is recalled.
yes, sir, she has partial insights, sir, but some of the content were totally irrelevant, sir.
Was she developed at any time a seizure?
Sir, only one episode of seizure, sir, during the last admission. Between the 3 months of time, there is no history of loss of consciousness or seizure-like episodes during these 3 months.
Okay.
During all 3 admissions, she developed only one time she developed GTCS. After that, she started on levetiracetam. After that, she had no episodes of seizure since 4 months.
Any memory disturbances she had in between this? Any episodes?
Sir, in between, she has some sleep disturbances and some form of memory disturbances are not affecting daily activities, but episodic memory impairment is there in between the episodes also, but not significant.
Okay.
In between also third episode, between third and fourth admission, she's having some complaints like sleep disturbances, irrelevant talk, but not significant. She's able to carry the activity on her own. Along with other CS of proteins we sent, other CS panel. We also repeat
Yeah,
method.
Yes.
She agreed for AV.
Please go ahead. It's not audible, but we are not.
Check your connectivity, Karthik.
Sir, can I add? I'm audible, sir.
Yes.
So we started on IV immunoglobulin instead of methylprednisolone as we developed steroid-induced myopathy and also to prevent long-term complications of steroid. We gave 2 grams per kg.
Slides.
You are in the first slide.
You are in the first slide, Karthik.
Karthi, what happened?
Now it visible, sir?
Yes, yes. Go back to the previous slide.
This one, sir.
Please go ahead.
Start from here.
So this time they're willing for autoimmune encapsulated panel along with other CSF proteins. We sent other CSF proteins, TC, DC, others are normal. We are waiting for autoimmune encapsulated panel report. We also, to rule out paraneoplastic encephalitis, we done with CT chest abdomen to rule out malignancy. They are negative. Paraneoplastic was not sent at this time due to affordability issues. We also did CT angiogram and vasculitis workup, including ANI immunoblood, to rule out primary or secondary CNS vasculitis, which become negative. This time we planned for IV intravenous immunoglobulin because of recurrent encephalopathy and also to prevent long-term complications of steroid-induced myopathy. So we started, they are agreed for IVIG. We proceeded with 2 grams per kg IVIG for 5 days. And she started improving. We discharged an azathioprine, antiplatelets, statins, and levetiracetam. Azathioprine we started with 550 mg PD. 2 weeks after started IVIG, she started improving the form of orientation to time, place, persons, decreased hallucinations, delusions. There is no abnormal behavior. Tremulousness also diffused, which we should seen in the last video. This is the post 2 weeks of IVIGs.
But without an autoimmune panel, you arrive at a diagnosis of autoimmune encephalitis, recurrent.
Autoimmune panel we sent the report. It came negative.
Came negative, huh?
Yes, sir.
How many percentage of autoimmune encephalitis are negative in general?
Sir, 20 to 30%.
Yeah, 5 to 15% of the autoimmune encephalitis may be negative, seronegative.
Seronegative.
After starting your IEAG, the symptoms has come down.
Yes, sir. Dramatically improved, sir. On the third, fourth of IEAG, she started improving.
Among what type of autoimmune encephalitis, the psychiatric the manifestation more?
Sir, normally is NMDA encephalitis, sir.
NMDA.
NMDA encephalitis.
NMDA receptor encephalitis.
Yes,
when
sir.
compared to LJ1, encephalitis it is more prevalent than NMDA.
Yes, sir.
And so psychosis, suicidal ideation, hallucination, delusions more common. And also with anxiety, mutism.
Mutism, apathy is more common.
Aggression and violent behavior also, agitations. The patient may respond to your IVG. Any other diagnosis thought of apart from NMDA? Casper 2.
Thought of.
Huh?
Sir,
I think clinically.
NMDA we are not suspected. Actually, we thought of some seronegative autoimmune encephalitis because NMDA the age group is against the NMDA encephalitis. Most young age group, sir. It is around 20 to 30 years.
Sometimes rare atypical can present because LJ even more common above 60.
Yes.
LJ1 encephalitis is above 60.
Yeah, sir. NMDA it is young age, sir. LG1 is in all age group.
Sometimes it can present.
Yes.
What about Casper 2?
Casper 2, there is no other symptoms. It will present like peripheral hyperexcitability.
Yeah.
There is no symptoms like that in these patients.
What is flame? Flame.
Sir, febrile illness related encephalopathies.
Flame
Flame is Mugad. Mugad finding. Karthik.
Oh,
Very recently they coined the term.
Mugad finding flame. Flare.
The part of NMDA. Flare hyperintensity is seen. MRI is there any
flare.
finding?
Okay. Sir, MRI only gliotic change in the right temporal lobe, sir.
Yeah.
There is no other significant findings in the MRI.
Sir, Vian sir. Nirmal, what is your thought about this?
Sir, since all known antibodies were negative, sir,
Yeah.
initially thought of Hashimoto's, but TPO also was, titers were very low. So seronegative autoimmune encephalitis is our final diagnosis, sir. But the one key point is that the criteria coined by Grouse et al. In 2016 says that either MRI or CSF has to be abnormal for us to call it seronegative autoimmune AE. But in this patient, all those were normal, sir. MRI was almost normal except for a gliotic foci in right temporal lobe, and CSF also was normal, sir. So
could it be a post-infectious autoimmune encephalitis?
Sir, but
recurrent encephalitis can happen in post-infectious, usually HSP, and the patient subsequently develop autoimmune encephalitis recurrent.
Yes, sir. This is multiple episodes. She
Yeah.
had like 4 or 5 episodes of which was steroid responsive initially. Then she responded to IVIG, sir. Multiple episodes. So this pattern usually fits into Hashimoto's, but TPO were low titers. So our final diagnosis is autoimmune seronegative autoimmune encephalitis only, sir.
Okay. Okay. Sir, Vian sir, anything you want to ask? Manigaran sir, Megaran sir, Nadesan sir.
So autoimmune encephalitis of this recurrent type.
Yes.
And what was the initial? Initially, she presented with headache and slow deterioration of mentation with a delusion hallucination. Yes. I was thinking in terms of Lewy body dementia or something like that. And suddenly everything changed and it became...
Could it improve well and again go for relapse and recurrence can happen in Lewy body? So in this patient, the patient absolutely recovered from this and again she developed the problem. The recurrent episodes.
So that is why. But initially it started with a severe headache.
Yes.
And so I thought some sort of cadasal, like that, some picture like that, encephalopathy. I never thought like that. Then it looked like a recurrent episodes of infective or para-infective pathology like. So it is autoimmune encephalopathy is a very strong possibility.
Yes, sir. Yes, sir. I have seen that one episode of HSV infection because patient also has got a evidence of mesial sclerosis, mesial temporal sclerosis, HSV infections followed by autoimmune recurrent episodes can happen.
Yes,
in the literature.
Yes, sir. There's a strong possibility.
Yes, sir. Vian, sir.
Again, is her improvement with IVIG.
Yes, sir.
Again,
yes, sir. Past 4 months, she had no relapse or recurrence.
There's a very strong possibility for
autoimmune. Is responding to your
IVIG.
Any other things to contribute, sir? From anybody from the forum? Nirmal, anything? else to discuss? You are waiting for autoimmune panel.
Autoimmune panel is negative, sir.
Negative, but I think we thought of seronegative. Okay.
Yes, sir. Yes, sir.
Okay. Any other genetic panel have you sent?
No, sir. Since he was responsible,
Patient not able to afford that means you are not able to do it.
No, but
RNA plastic only we planned, sir. Genetic we are not planned it.
So this patient was responding to immunotherapy, sir. So we didn't think in terms of genetic disease, sir, because
every time she's coming with subacute onset of disturbances and acute onset of altered sensorium. That's why genetic we not.
Satish, what is your final conclusion about this case?
Sir, my conclusion is strongly autoimmune, sir. 2 points favor, sir. First is CRP, sir.
Among the autoimmune, what a subgroup you want to say? Probably clinically, the clinical features.
It's clinically the picture more in favor of NMDAR, sir, actually.
Yes,
she predominantly has psychotic features as a symptom.
Yes. More predominant, more than 50% of the NMDR patients can have all the psychiatric symptoms predominantly.
Yes,
sometimes patient may land up in psychiatric OPD rather than coming to neurology.
Yes, sir. Most often it happens in our college also, sir. We have picked up 3 to 4 NMDAR, sir, from psychiatry wards, sir.
Yes. The initial presentation, mostly in initial presentation, the psychiatric symptoms, florid agitation, acute agitation, and assault sometimes happens, confusional state, hallucination, delusions, florid psychotic symptoms. They land up in mostly the psychiatrist, from where they can refer here.
Yes, sir. So this patient had she had a NMDAR phenotype, sir. We saw 2 points pointed to autoimmune, sir. One is CRP, sir. CRP elevated every time, sir, 300 and above. And whenever she went for steroid taper, she relapsed the symptoms, sir.
Okay.
So she did well only on 60 mg of prednisolone, sir. So we can't give for a longer course. So we started an IVIG and steroid sparing. But even after that also, she had a myopathy. So she had some difficulty in walking at present now.
Okay. Good. Very nice. Sir, anybody from the forum want to discuss or differ from this?
Sir, I have one doubt. Why not still it is giant cell arteritis?
Karthik, you can say SN Karthik. SNK.
Yes, sir. The first thought was giant cell arteritis. Why it still can't be a giant cell?
Yes.
You can have psychosis, hallucinations, recurrence, relapse. It's still autoimmune.
Yes, sir. So autoimmune basis we strongly suspect, sir. But a biopsy would have, temporal artery biopsy would have given the missing things, sir.
Okay.
That was the missing link, I think, sir.
Biopsy.
Easy, IVIG response will be this much.
Okay, anybody want to share?
Sir, Dr. Thiru. So why not tuberculosis encephalitis?
Pardon?
It's tuberculosis encephalitis. Even though the CSF is normal, the picture may be the recurrent encephalopathy. Tuberculosis.
What do you want to say, Thiru?
Tuberculosis.
Okay. But other parameters is not, I think, there is no evidence.
The picture, the presentation may look like. Previously, we thought of tuberculosis before the emergence of autoimmune encephalitis, before the thought.
Okay.
There's always one possibility to consider.
So LP was normal, sir. CSF, no cells.
Yes, sir.
It was done twice.
So instead of this, so in the angle of thinking of SN Karthik, I thought that instead of calling it a giant cell arteritis with encephalopathy, like it is autoimmune encephalitis starting with headache, giant cell arteritis picture like, and slowly developing recurrent episodes of encephalopathy picture. So it is the whole thing is autoimmune encephalitis. Where the seronegative autoimmune encephalitis, which is yet to be identified. There are several cases of seronegative autoimmune encephalitis. Patients with the response, we diagnose autoimmune. So even starting with, instead of diagnosing as giant cell arteritis, going in for encephalopathy picture, starting with a headache and recovering with the steroid, then she started developing encephalopathy picture. And the whole thing is in autoimmune encephalitis. Instead of giant cell arteritis with encephalopathy picture, it is encephalitis with headache, later developing features of encephalopathy.
Yes, sir.
So PET scan, sir. PET scan.
PET was
PET
not
scan
done.
could not be done. Not available at our center.
Because of age group and PET scans might have some clue.
Excellent. Paraneoplastic we have to rule out, sir. Paraneoplastic plan and PET we planned, but at the time it could not be done with paraneoplastic.
But the response to steroids, the paraneoplastic may not respond so well to steroids, sir. That is one point clinically we are against paraneoplastic.
Okay. Is there anybody to share, sir? Share their view or differ? Otherwise, we will conclude the session, sir. VN, sir. VN, sir, available? Okay, no response. I think probably Satish Kumar and Nirmal, I thank the department presenting the very interesting rare cases to the forum. I congratulate Monica and Amara. Thank you very much for this wonderful presentation to this forum, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Thank you, sir. Do எப்படி அவ்வளவுதானா அவ்வளவுதான் வீடியோ